Hello, my name is Arya Javidan. I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on bridging the gap, innovations in telebehavioral health access, and it is hosted by the Southwest Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few housekeeping tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat for communicating issues with technology or communication access issues. Please refrain using the chat feature to ask questions or make comments. Please note that closed captioning is available and that is located at the bottom of your screen. Today's webinar is also being recorded and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to today's moderator, Tara Scalar.
Thank you so much, Arya, and welcome to all our participants. My name is Tara Sklar, and I work with both the Southwest Telehealth Resource Center and the Arizona Telemedicine Program, where I advise on telehealth law and policy. I'm also the faculty director of the Health Law and Policy Program at the University of Arizona, James D. Rogers College of Law, where I teach a course in telehealth law and policy. So I have required my students who are in the course right now to attend today's session, and I'm really glad to see many of them here. We are very fortunate to have 3 nationally recognized panelists today, including Ms. Teresa Langley, Dr. Sarah Gibson, and Dr. Jay Shore. We'll be discussing a wide range of telebehavioral health across the country in areas of the law and policy, virtual prescribing of controlled substances, innovations happening in the field, particularly in the Southwest, and then along with that, implications in the growth with AI, and at the core of a lot of these issues, how to better ensure equitable access to this essential healthcare service, especially given the digital divide. So the general flow for the day, as Arya mentioned, anytime you have a question, please use the Q&A. I will be monitoring it very closely and really do plan to incorporate your questions into today's webinar. If not, we will try to get to them after via email. Before I introduce our first panelist, I just want to also acknowledge the Southwest Telehealth Resource Center, which was created to advance the effective use of telehealth throughout the Southwest, including Arizona, Colorado, New Mexico, and Nevada. The Southwest Telehealth Resource Center assists startups who are just beginning a telehealth program to those further along in their development across a range of areas, including technology, policy, evaluation, and forming community partnerships. So with that, our first panelist, Ms. Teresa Langley, will really do, I saw her slides, so she's going to do a great job just laying out the regulatory landscape in this area. And she is senior counsel at the national law firm Pierce Blackwell, based in Houston, Texas. Her practice focuses on health law, where she advises hospital systems, physician groups, mental health providers on a variety of state and federal regulations, including fraud and abuse, Medicare, Medicaid enrollment and reimbursement, confidentiality of health information, and then particularly relevant to today's webinar on the changing regulatory landscape surrounding the provision of telehealth and telemedicine services. So with that, I will turn it over to Ms. Teresa Langley to present her slides, and then we'll do a little bit of Q&A.
Thank you, Tara. I appreciate that introduction. So let's get my slides going here. Okay, you should be able to see that.
Yep, thank you. Yep.
All right, so I'm going to give you an overview of the legal background, specifically legislation and reimbursement rules that have developed since the COVID-19 pandemic. Before the pandemic, telehealth was relatively uncommon for many reasons. There was a lack of federal and state legislation addressing telehealth. There was limited reimbursement on a government and commercial level. And for Medicare specifically, reimbursement was limited to only patients located in rural areas in a specific type of medical facility, like a nursing home. So the pandemic led to a huge explosion in the use of telehealth. Just to give you an example, there was a national study done and it showed that telemedicine encounters from the time period of March to June 2019, so that was the first 3 months of the pandemic, telemedicine encounters increased 766% during that time period. So that was an increase from 0.3% of all healthcare interactions being telemedicine up to 23.6% of all interactions being virtual or via telehealth. So huge explosion. Expansion during this time was due to federal and state waivers that relaxed restrictions that were previously in place and expanding reimbursement. So flexibilities that were put in place during the pandemic expanded the locations where virtual care could be provided, the types of services that could be provided virtually, and the types of providers who were allowed to do that. The goal with this was to alleviate pressure on the healthcare system that was obviously overburdened, and also allow patients access to care without, requiring them to expose themselves to the virus if it was not necessary. And so the federal public health emergency officially ended on May 11th, 2023. But the flexibilities put in place during that time, a lot of them have been extended. And we're going to talk about that. So here are some legislation that was passed during and beginning with the pandemic. And I'll give some background on how telehealth was expanded during this time. So in January 2020, HHS Secretary Azar declared a public health emergency. And in March 2020, President Trump declared a national state of emergency under the Stafford Act. So those two things in tandem allowed HHS and CMS the authority to issue a bunch of federal and state waivers. And so they did that. They allowed licensure practice across state lines. They expanded Medicare coverage, and they permitted discretion in enforcement. So there were a series of bills that were passed that you can see here. And so to touch on those, the Coronavirus Preparedness and Response Act of 2020 granted HHS discretion to issue those waivers, and it waived the Medicare restrictions that I was talking about. So telehealth was no longer restricted to that only rural sites and only very specific locations. And then most recently, the Consolidated Appropriations Act of 2023 extended a lot of the flexibilities put in place, and it also removed the geographic restrictions and extended those through December 31st, 2024. So Medicare reimbursement is really important, and that is because a lot of state Medicaids and commercial will just follow kind of where Medicare leads. So Medicare is kind of setting the bar for how a lot of things are handled. So some temporary Medicare changes that were put in place through December 31st, 2024. Patients can continue to receive telehealth at any location, including at their home. They don't have to be in a rural area or at a specific originating site, and there are no geographic restrictions. Telehealth services can be provided by all providers who are eligible to bill Medicare for professional services. And then finally, specifically for behavioral health, the in-person visit requirement, where you have to do that in-person visit within 6 months after that initial telehealth visit, and then annually after that, is not required. Note that that requirement will go back into place after December 31st, 2024, if these extensions are not continued forward. And then there are Medicare permanent changes that are really significant for the telebehavioral health space. So permanently, providers can provide behavioral telehealth services with no geographic restrictions on the patient's location. So again, the patient doesn't have to be in a rural area at a specific facility. They could be located at home or elsewhere. Behavioral telehealth services can be provided via audio only. And so that's kind of special. That's not something that's consistent for a lot of other services. Mental health counselors and marriage family therapists have been added as eligible practitioners to bill. And then FQHCs and RHCs can serve as distance sites for behavioral telehealth services. So these are permanent changes put in place. They're not going to expire in December 2024. So you can see the Medicare telehealth services from the Medicare physician fee schedule listed on the link here. There are a couple of new codes that were added for 2024 that may be relevant for behavioral health providers. One of them is, on a permanent basis, the social determinants of health risk assessment has been added. So there's a code for that. And then on a temporary basis, health and well-being coaching services have been added. So those two codes are there. State Medicaid reimbursement, again, often this will track Medicare requirements, but states do have some flexibility in paying for telehealth services with Medicaid. So you have to pay close attention to the state statutes applicable to the Medicaid program and the state manuals. And you can see what states' requirements are from their approved state plan amendments. Commercial, again, that's going to vary by private plan, and they could possibly have specific requirements for that payer on how to bill, what modalities are required for telehealth, cost sharing requirements, prior authorization requirements. So it's important to look closely at the provider agreement and the provider manual to see what is available for telehealth. So this is really important for reimbursement. The Mental Health Parity and Addiction Equity Act. This is a federal law that prevents group health plans and health insurers from restricting mental health or substance use disorder benefits more than they would be for medical or surgical services. So there's an equity requirement. If these plans are going to provide mental health or substance use disorder benefits, they need to be doing that on the same level as they're providing medical and surgical benefits. So this really does apply to most plans because though it only applies to plans that do provide those mental health and SUD benefits, plans are generally required to, because this is an essential benefit under the Affordable Care Act. There are exceptions. So you can see here listed self-insured, government and private employers that have 50 or fewer employees are exempt, and also group health plans and issuers that have a cost increase. There's an exemption available for the next year, but it only lasts for that year, and then the requirements go back into place. So another really important area is prescription, and specifically for controlled substances. So generally, the Ryan-Haidt Act requires that there be an in-person medical evaluation before a provider issues a prescription for a controlled substance. That's the baseline rule. During the PHE, there's an exception that allows providers to prescribe controlled substances without first having that in-person medical examination, if certain requirements are met. So they do need, the visit needs to be through a synchronous audio video interaction, and it needs to be for a legitimate medical purpose by a provider who's acting in their professional practice. And this exception has been extended through December 31st, 2024. So this is still in place. We've yet to see what further extension or flexibility is going to be developed here. Notably, the DEA is supposed to put in place a registration process for telehealth providers to be able to sign up and issue prescriptions via telehealth, but that has been pending, and they have yet to issue proposed rules on what that looks like. Another really important kind of legal compliance area is privacy and HIPAA. So the telehealth platform does need to comply with federal and state privacy laws. The Office of Civil Rights did have a period during the public health emergency where they exercised enforcement discretion. So if providers were providing services in good faith during that time, they were able to use non-HIPAA compliant platforms. So providers were used to using, FaceTime, Zoom, Skype on their phones to chat with patients. That period has ended. So since 2023. So now providers do need to be using HIPAA compliant platforms, And there are listed here some vendors who certify that they are HIPAA compliant and they will enter into a BAA. And, this may require some updates to policies and education to providers. A lot of providers started using telehealth during the pandemic and were used to those flexibilities that were in place. They may be used to jumping on their phone and using whatever app is available that they would normally use and not be aware that, there's some more formal requirements in place now. There also is issued guidance on audio-only telehealth, and that is really particularly relevant for the behavioral health space because those behavioral health services are some of the only ones that Medicare is going to reimburse on an audio-only level. So just making sure that providers are interacting in a private setting, using a low voice, identifying the patient, and documenting how they're using those safeguards in the EHR. Okay, so that is the end of my slides. And so Tara, I can hand it back to you for any questions.
Great, thank you very much, Teresa. So I think you did such a nice job just setting the stage with where we currently are at this point on June 12th. We don't know quite what's going to happen in end of December 2024. So with that in mind, giving this changing regulatory landscape that many have described as also an uncertain landscape, particularly with reimbursement, what are some of the best practices that you recommend for those of us on the call that either are providing telebehavioral health services or want to know how they would do so if their practice currently doesn't do that and they're wary of what to do given all the changing laws and policies?
Yeah, definitely. So I think there's some best practices we can talk about that really are consistent across provider types and across clinical settings. So one of them is licensure. Generally, the provider must be licensed in the state where the patient is located, and that's going to be across the board. There are some exceptions to this. So there are certain state exceptions where, maybe the patient is traveling for a specific period of time where it would be permitted to care for them. But generally, this is the rule that needs to be followed. The provider needs to be licensed where the patient is located. There are some options for flexible pathways. For example, there's licensure compacts, and there are multiple depending on what type of provider. So there's the Interstate Medical Licensure Compact for physicians. So providers can apply and then gain access to licensure in multiple different states through that venue. There are also some states that have kind of an expedited telehealth registration process. So that's kind of faster than going through the normal licensure process where you do still have to apply and kind of submit all of your materials, but they will expedite it and rely on your licensure in the other state to some extent. Also, it's important to note for telehealth providers, they're subject to the same standard of care and the same kind of documentation requirements as they would be if they were meeting with the patient in person. So I think this is really important, especially in the area kind of compliance and enforcement. There are certainly telemedicine companies out there that are trying to contract with providers and encourage them to issue prescriptions or order medical devices or testing when they haven't really evaluated the patient or met with the patient in a sufficient way to meet the standard of care and show medical necessity. So it's really important to make sure that you're still meeting those same kind of standard of care expectations and documenting how that's happening in the medical record. Informed consent is super important as well. And so when you get informed consent for telehealth services, you want to incorporate some language, making sure that the patient is consenting to that the service is being provided virtually and the platform. And this could incorporate some language like, the patient recognizes there could be connectivity or technological issues, and they may need to reconnect depending on the situation, just making sure that they agree and understand that this is not just the care they're consenting to, but also that it's being provided virtually. And then, telehealth providers are restricted by their scope of practice and their licensing board in each state. That's going to be the same as it would be in in-person services. So really, these telehealth requirements, they're not letting providers do more than their scope of practice. they're not letting providers do less as far as standard of care or medical necessity. And then finally, telehealth providers should be aware, knowledgeable about professional liability risks and coverage. When you're practicing on a national level, it's important to note the states really do vary on this. For example, Texas has medical malpractice coverage caps. And so that liability is really lessened, whereas that's not going to be the case if you're practicing in other states. So that's kind of the high points I would touch on that we want to keep in mind for compliance purposes.
Oh, thank you. We covered a lot of ground there. As you were speaking, we've actually gotten some questions from the audience, and including comments saying excellent speakers. So I wanted to pass that on. And then one of the questions is, and I think we see this a lot with psychiatry in particular, but for self-pay patients, they wanted to know, would there be any issues with the requirements and flexibilities that you've been describing under reimbursement for self-pay patients who don't use insurance? Any thoughts on that?
Yeah, definitely. So I will say, I mean, there's a lot more flexibility for self-pay patients because they're not subject to the requirements of either governmental payer reimbursement requirements or commercial payer requirements. So really for self-pay patients, what the provider needs to be observing is the law of the state. So what does that state define telehealth as? What modalities are required based on state law? And then if it's pretty open-ended, for a lot of states, there may not be really specific restrictions on that. There's a lot more flexibility on what you can do. Again, there should be good documentation and support for how that service is meeting the standard of care and showing medical necessity just from professional practice standpoint. But there's not kind of the same rules and restrictions around what you need to prove to get that reimbursement.
That's great. And I think for those of you on the call, I know you're from all across the country. The telehealth resource centers are part of the Center for Connected Health Policy, CCHP. And if you go to their website, you can click on your state and see specifically how telehealth is defined, which might help you and get at some of the points Teresa was describing that do vary by state. Our last question actually revolves around the issue of the Ryan-Haight Act and what may happen at the end of December. And they're asking, for a controlled substance, something that could be very, commonly used for ADHD in particular, what could happen at the end of December if the Ryan-Haight Act returns? Would you only be able to prescribe those medications if in person, or would it be something you would do if you met them in person, but then after that you could virtually prescribe? I know there's so much confusion and the DEA hasn't weighed in quite yet. So what are your thoughts in that area?
I mean, this is really up in the air because we've been operating for a while under the pandemic exceptions. So we really are kind of waiting to see what the proposed rules are from the DEA on what they want this to look like next. And the industry, I think, has spoken and is expecting them to provide some level of flexibility permanently moving forward. And something that they are supposed to do under legislation is put in place this telehealth registration process. So that is something that we're looking out for. But it is, I think it's to be foreseen. But if we were to go back to, non-exception land, then the requirement for an in-person meeting with the patient before you issue a prescription is going to be reinstated.
Great. Thank you so much for a wonderful presentation and answering these questions. I hope you're able to stay on for the rest of our panelists. And at the end, I think we might come back to looking ahead, how can we be sure to be compliant with telebehavioral health services? So thanks so much, Teresa. Go ahead. Okay. I'll now turn it over to, I'll now introduce our next panelist, Dr. Sarah Gibson. She's going to present on a range of innovations that she's been seeing in telebehavioral health from the perspective of Blue Cross Blue Shield in Arizona. Dr. Sarah Gibson is a psychiatrist and medical director of telemedicine for Blue Cross Blue Shield of Arizona Health Choice, which is in Flagstaff, Arizona. She oversees the North Central Arizona Telemedicine Program for mental and physical healthcare integrated systems. Clinically, she's provided comprehensive psychiatric services to rural Apache County solely via telemedicine for nearly 30 years, including 23,000 direct patient services over that time. We very much appreciate you joining us today, Dr. Gibson, to share your passion about providing high quality, holistic, and timely medical care to underserved persons and places. Thank you so much.
Thank you. Yes, we've been around the block a little bit in behavioral health and in rural behavioral health, especially in Arizona. So just the briefest background, this is what we were looking at almost 30 years ago when some of us rural behavioral health providers started trying to figure out some solutions and figure them out quickly. For example, here's the state of Arizona, and we were looking at almost 2/3 of Arizona's square footage area, but only a population of 11% of Arizona. So there were large distances with very few people. So we couldn't be supporting, full-time psychiatrists at the time. And so we dove into telemedicine with a vengeance. And my thoughts when we talk about innovations in telebehavioral healthcare is that we've been doing that for 30 years almost. We've been highly innovative, we've been highly successful. I think of it as a tree where we were just branching out and figuring things out and diving in and doing whatever we needed to do. And we worked very hard and we innovated. And now we're at a place, and then of course the pandemic hit and we really had to get creative again, another layer of creativity and innovation. And now we're at a place where we need to settle. We need to stop branching out and start deepening our roots and really getting our foundation back strengthened and underneath us. So part of that is, as the excellent lecture we just heard, was we need to really enhance and clarify our regulatory support of what we can and cannot do and what we should be doing. Another big issue, and this is across all of healthcare, but it comes to the fore in telebehavioral health, is mitigation of fraud and abuse. And I personally believe that one of the major concerns of the DEA and of some of the other issues is more about identity verification, and that the correct patient is getting the correct prescription for the correct diagnosis, and that correct patient can be a big problem. And so that's an area that I believe that we're really going to be looking at. And then my passion is, what can we do to improve our care quality as care providers? So we've got this technology going, and what can we do to leverage technology so that it is supporting the practice of medicine or the practice of behavioral health in its healing modality rather than being a distraction? We need to move the technology to the background, bring the clinicians to the forefront to be advising where we're going with setting up these systems. Part of that is using our technology to develop more of a community of practice where we get together multiple groups. And also in our system, we're really looking at mentorship and how we can use telehealth administratively to really bring providers together in a community and doing mentorship. So technology can help us practice at the top of our license so that the terrible things that we've had to do over the many years of documentation into the night and filling out our EHRs and trying to figure out non-clinical things, those are things where I hope that technology can be helping. Another amazing area that we're trying to really focus on right now, you can think of a home visit as a house call, and that was in one of these lectures that recently that I thought was a great paradigm to think about. but trying to really work on utilizing telehealth as a diversion from urgent care in the emergency room. And then also, we are identifying patients who have not had primary care for over a year or 2 or 3. Some have never had a primary care visit, and so they're lacking in the basic health needs. And so we're outreaching to patients who have not seen primary care and offering them in-home immediate telehealth sessions to try to bridge some of those gaps. But really, my major point is talking about mental illness and substance use disorder. They're chronic diseases. These are long-term issues. If you think about things like hypertension and diabetes, you can't just give a pill and fix it and you're done. And in the mental health arena, especially the medical, behavioral health medical practitioners, we're asking people often to take medications that are difficult to take. They might have side effects and they might not work right. And so we really need to be practicing in a relationship of trust. And we need to be utilizing what is telehealth? It's connection, right? So to set up for success, yes, we need competence. We need to know what we're doing. We need to know the right pills. We need to know all that competence. But we also need a connection in order to really think of these illnesses as a chronic disease model. Kindness is a term that you don't think about when you think about technology. Kindness is a whole concept that has been proven to increase health span. And health span is in contrast to lifespan. Lifespan is how long you live. Health span is how well you live during that time. And so using these concepts of connection, kindness, warmth to increase our healing and our connection and our efficacy and our outcomes. So, well, this was an interesting study that if you are lacking social connection, your health outcomes are decreased to the point of as if you were smoking 15 cigarettes a day. We're in the middle of a mental health epidemic, overdose, and an opioid epidemic. Fentanyl is just devastating our communities, often in your rural areas, in all areas. So basically, if we are in a position of physical distancing, the addition of telehealth with that together, we can pull together a social connection. And that, I will end with that.
Oh, that was wonderful. Thank you so much, Dr. Gibson. Well, one issue that we've been talking about in preparation for this webinar related to this topic is the opioid epidemic, and would love to get your thoughts on what we can do about that in this telebehavioral health space.
Well, it's devastating, and I'm sure you've all seen the recent statistics about fentanyl and how it's just saturating our population. And I was horrified to go to a lecture by our Arizona law, I think the sheriff department of diversion, and they, first of all, I should have sent some of these pictures. Pictures of fentanyl. It looks like candy. It's multicolored, yummy little candy pills. And that's what they are seizing and sequestering. And what I did not know that horrified me was that one pill in 73, I think, % of their seizures nationwide of fentanyl, 73% of those individual pills carried a fatal dose. What? And if you don't, if our kids don't know that, they're dying. And so that's not okay. So, our nation understands this. We're looking at this, and we changed our data waiver requirements so that more prescribers and medical providers could be providing buprenorphine and doing in-home inductions, and they're not. So what we're doing in Arizona is we're trying to really increase that community of support that I mentioned. We're reaching out to our providers both in primary care and of course mental health care, but everybody needs to be on board with this. And telehealth is vital to be able to provide the in-home inductions for safety, to really blanket the world with more and more tools that we need. I just heard from an emergency room doctor that, yeah, we'll give people buprenorphine, but they don't have anywhere to follow up, and there's no providers. Well, the providers are out there, but they're not willing to stick their neck out. They're afraid, and we need to be supporting to them, but also offering this modality of in-home induction as a huge life-saving opportunity.
Yeah, thank you. Thank you for bringing that up. And those are frightening statistics of just one lethal dose. And so another question that we've been also kicking back and forth is regarding the pandemic as we come out of it. And it'd be great to get your perspective of what you're seeing through Blue Cross Blue Shield across Arizona. What have you found that you've learned from that experience?
Well, it's funny. I mean, Dr. Shore has been around the block with me on this too. We've been doing this forever, and we thought we were really good at it. And then the pandemic happened, and suddenly we had to move into people's homes. And I think that he's going to be talking about the digital divide and some of the those issues. So I won't go into that. But that is a big issue. That when we went into the in-home provision of telehealth and of medical care was an absolute revolution that turned everything upside down. And so we did a lot of things. We provided tablets with data plans and to patient. And I think, I really think the bottom line is when you think about the elderly person in their trailer out near on the edge of the res with no transportation and a bunch of medical problems, you need to find a way that you can go to them because they can't come to you anymore. And if they do have to come to you, they're not going to make it. And so whatever we can do to help them out, and if that means providing more technology, and we can talk about that, but a kind person up front to help them connect in, to help them figure out how to push the right buttons on their screen. Those are things that are basic human kindness and warmth that can save lives and be very dramatic. So.
Oh, that's great. Thank you. Thank you for bringing in those basic humanity roles that we have and the delivery of care. And one of my students is living in a rural part of Arizona, and she's taking the course in telehealth, and she's like, we just have to offer this to everyone somehow because of that exact situation that you've described. Well, that was fantastic. Thanks so much, Dr. Gibson. Hope you're able to stay on while we move over to Dr. Jay Shore, our headliner for today's webinar. It's going to be talking more about the digital divide and particularly the role of AI. Dr. Shore has many hats, so I'll just introduce a few of them. But he is the founding executive director of the Brain and Behavior Innovation Center at the University of Colorado Anschutz Medical Campus. Also the vice chair for innovations in the Department of Psychiatry and a professor in the Department of Psychiatry and Family Medicine and the School of Medicine and Centers for American Indian and Alaska Native Health at the Colorado School of Public Health. It seems from your resume, very, very involved with the Veterans Office of Rural Health Veterans and the Chief Medical Officer for Access Care Services, which provides telemental health services to Medicaid and rural populations in Colorado and Alaska. Your career focusing on technology and mental health, ongoing development, implementation, assessment, particularly for the underserved populations, Native Americans, rural, and really thinking about how to bridge that digital divide going forward. So just so excited to hear you speak, Dr. Shore. I will turn it over to you.
Great. Thank you for the nice introduction. Can you hear and see me clearly? I assume, yes, we're good.
Absolutely.
Good.
We're great.
And you're seeing my slides, correct?
Correct. Yep.
Okay. Well, I'm just gonna briefly talk about two specific topics of emerging themes and trends from the pandemic. I do, as mentioned, I have multiple roles, and just in the interest of disclosure, I'm talking for myself today, and not representing any of the organizations that I work with. So that's my disclosure side. So I wanted to just briefly, for a few minutes, talk about the digital divide, and particularly in the context of COVID, and then shift gears a little different, but some similar themes about AI and its impact in mental health care, and specifically telemedicine. So the digital divide as a concept that has been there for a long time, and I think most people understand it's the idea of being able to access technologies, and particularly in healthcare, to get your healthcare. There are many different ways people have conceptualized it. The way I've sort of simplified it for myself is there are actually five. This is a little bit of the old slide. I see five key components that if you're a patient and you want to access healthcare, obviously you need adequate broadband access. And I think that's the most obvious thing that comes to mind when we think about the digital divide: having an adequate broadband to access video conferencing, patient charts, digital imaging for your providers in rural area. You obviously need the up-to-date technology, right? You need both the software and hardware to run whatever applications or programs to be able to access care. You need tech literacy, not just broadly, but very specifically, right? We all have these different ways to connect with patients and into healthcare systems. So you may be sort of comfortable on a computer, but if your healthcare system has a complex way of scheduling through a patient portal with video conferencing, you need that specific tech literacy to use the application you're being asked to use. And then you need tech support. And it's very challenging in many, many systems. To me, real tech support is real time when you're doing a clinical session, either a patient or provider. And many, many systems work on a ticketing type of tech support where you have problems and people get back to you within a day or two or even longer. And that really inhibits good technological care. And then the fifth issue is a little broader, but it's having a mechanism to pay for this. So that means having insurance or some kind of healthcare coverage that allows you to get healthcare, and then having healthcare insurance that allows you to have digital access. And those are not necessarily always aligned. I think COVID was like the Leonard Cohen song. One of his lines, he says, "There's a crack in everything, and that's where the light gets in." And I think with COVID, on one hand, we saw the power, especially during the quarantines, of telemental health and creating care and access that people just would not have been able to get without it. But then the crack was that we saw significant populations completely cut off from healthcare because of one of these challenges with the digital divide. We saw increased morbidity and mortality in specific populations, including rural populations, American Indian, Alaska Native populations that I work with, driven by some of these access issues. So I think sort of the good thing about COVID, it sort of did a spot check of a report card of where we are as a country with these issues. And I think it is really critical that we stay very focused on these. And I think in each of these areas, there are large room for improvement. And particularly if a pandemic hit again tomorrow, like the one we experienced, I'm very concerned that we would continue to see some of the significant disparities that were there, meaning the system level problems have not been solved. So that's one sort of, not sort of, but an emergence policy issue out of COVID. And before I switch, I would say on the positive side, when I was working, what I saw is, a lot of challenges about the digital divide, but I saw a lot of creativity, right? And if we could just capture all the different individual and organizational lessons of how people solved all of these areas, I think we'd be well on our way to a solution toolkit. And so one of the stories I thought was very creative, I worked with a rural organization that had to lock down a hospital during COVID. At one point really couldn't have patients all coming into their hospital facility because of restrictions. So they were doing care out to the community into people's homes, but many of their patients didn't have adequate bandwidth. So they jacked up a van, putting a satellite dish on it with satellite internet, and they would actually drive this van outside a patient's house so the patient could then get on this mobile Wi-Fi that was adequate enough, and then that would allow them to video conference back with their providers. So again, I have given whole talks. I can give you 20 different examples. So, but just the flip side of the COVID, that there was a lot of creativity and problem solving and lessons that we really want to capture. I think totally shifting gear a little bit is AI, right? And I think we've been hearing a lot, particularly in the last year, about sort of the promise and perils of AI. And I would say some AI anxiety that Skynet is going to become live and possibly take over the world. I think both the risks and the promise of AI right now, for those of us who have a little familiarity and working in the film field, are a little overrated or exaggerated currently today. Who knows what the future will develop? First of all, I think AI is a long way of being a significant risk for catastrophe, although it is something we need to monitor. I also think right now that AI is in this phase where there's a lot of excitement of how to use it in healthcare, but a lot of uncertainty of how to really implement it and make it effective. I think that over the next 5 and possibly 10 years, because it takes a long time in our healthcare systems organizationally for these innovations to diffuse, there's a number of areas I think we will begin to see AI and machine learning for telehealth. And these include things like smarter electronic health records that help you with both documentation assistance, but maybe even suggesting, as you are seeing the patient, potential avenues, treatments, helping with care coordination. Specifically in telehealth, there's been many for a long time who've dreamed of having a video conferencing overlay that gave providers feedback on body language and diagnosis through video signals. And the technology has never really been able to deliver that. I do think there's some promise in AI moving forward for that we may see. And then obviously, I think AI can be very helpful in care coordination and treatment execution across systems. Although, again, these are all very theoretical. I think sort of the two biggest real risks of AI is, I won't go into that slide, or maybe I'll end with it, is one risk is, if you look at, this is the American Psychiatric Association cultural framework for the assessment of patients. And the basic framework is that you have patients and providers interacting through Western medicine. And and culture is the medium that really determines those interactions that include the impact of both patient and provider background. Over the last decade, we've really layered technology over that interaction, both AI and video conferencing. And the risk here, and I've cutely called it the texture, the cross between culture and technology. I'm not sure that's the best word, but basically we really need to pay attention about how video conferencing and other technologies may impact and lead to potential built-in biases as we treat patients. There is data and literature coming out of this. I think the most well-known in society is some of the problems with facial recognition technology. And we have the same types of danger in health and in healthcare as well. And then, of course, the final, I think, risk of, and I'll just leave up a few resources with my final comment. I think some of the final risks of really AI is not the AI itself, is that how people will choose to leverage it, right? It's a tool like many tools, and we've certainly seen tools in healthcare be leveraged for the wrong reason. If AI is getting leveraged to maximize throughput or stockholder value in the for-profit medical industry versus quality of care, I think that's our most immediate risk with AI. But again, there's, I think, both a lot of potential that will hopefully come to pass, but there are these risks, and I think that there needs to be more thoughtful, proactive national policy and legislation as we move forward looking at these. So that, I'm just watching my time, and I'm at 10 minutes. There's some contact information, and I'll stop sharing, and that's the end of my comments.
That was great. Thank you for that high-level overview on those issues. Also, just my thanks to all the panelists. All of you were very prompt and with your presentations. I so appreciate it. It's great that we're right on track. So with that, I do encourage everyone listening to submit any questions you may have in the Q&A. I have just a few for Dr. Shore, then we'll open it up to the wider panel. But Dr. Shore, you specifically talk about the digital divide, and you mentioned broadband and connectivity in general, but are there any specific solutions that you'd like to raise at this point?
Well, and again, I think actually that there is some legislation and rural grant programs that have been looking at this for years and years. I think to really address this, that we need to, as a country, take on a systematic review of sort of our tech and infrastructure, and really what the investment should be, and not just for rural, but other communities. There's urban communities that have disparities in this. And so I know there's been some talk about this. I know right now the focus nationally is in our elections, but my optimistic hope is when we get through that these conversations will continue and increase.
Yeah, absolutely. I mean, I think everyone sort of, I guess I'll speak for myself, just surprised at the Affordable Connectivity Program ending, even though it has incredible bipartisan support. And could there be something that could happen at the state level to provide some subsidies in the interim? Great points. And you really explained the AI fears and risks very well. I found it very interesting. One of the panelists commented on how she's using AI in her practice and finding it helpful. Are there any other implications there that you'd like to raise before we turn it to the broader panel?
I think there's a real promise, particularly in telehealth nowadays, that AI, there's a real promise, particularly with documentation, that AI has the potential to take documentation away from us and support us in a good way. There are some companies that have been piloting, and people may see it even with your Zoom, these transcribing features. We may get to a place shorter than we think where you do a Zoom call and all you really have to do as a provider is review the note. And one that will, I think, both increase throughput, decrease provider burnout, and also allow more focus on a patient. Because all of us providers, even if we're working our hardest to be really present with the patient, you also have to manage the administrative burden, which has increased over the last couple decades for providers. So I think that's an exciting area to watch, and I'm optimistic, and I know some individual providers are already digging in and using it. I'm beginning to see some systems. I think we're in early days, but I look forward to seeing what develops.
Yeah, that's a great point and a great intersection with law and compliance as well on the issue of documentation, and where AI could really help make sure that providers are checking the boxes they need to check when they're writing up their notes. I don't know if Teresa, if you wanted to comment on that, or if anything you're seeing with your clients.
I'm sorry, would you mind just repeating the, so I make sure I'm responding appropriately?
Oh, sure. We were just talking about, one of the great uses of AI could be in supporting documentation for providers. And I just think that has such a promising intersection with law and compliance in the area in terms of making sure that what is being documented is suiting, whether it's with HIPAA privacy or informed consent, whatever they're documenting, how the visit went for reimbursement purposes. I was just curious if you're seeing any of that in your practice.
Yeah, thank you for explaining. I totally agree. I mean, obviously it puts something together that needs to be checked, right? So especially where we're at with it, you couldn't rely on it kind of putting together the notes and not having the provider review for accuracy. But absolutely, any efficiencies I think that assist with documentation, making that process more thorough and faster is going to be a huge benefit for providers, and something I'm sure they're interested in incorporating. Already with EHR, I think we have some kind of like automated templates that are really helpful, but they also need the provider to weigh in and customize for that specific patient and situation. So I would see it as kind of a better, more amped up version of what we have kind of built into the EHR systems.
Great, thank you. And before we let everybody leave, we have one last question for the group. And this is, I like this question because I think it explains some general confusion in the area of delivering telehealth and also like what may lay ahead. But it's from a student of mine, and he asked, how do providers typically verify patient information? And he wanted to know how you would do it synchronously and asynchronously, and whether that could be something that changes. And I think that's interesting given Dr. Shore's comment about biases in facial recognition and how that could potentially impact identification too. So, so Dr. Gibson, I might start with you in terms of what you see in your practice with that direct patient care, and how you identify patients, how you might see that changing as the technology advances.
So yeah, here again, we're butt in the seat, just figure it out. And so for many years, most of the telebehavioral health was provided to a patient in a clinic. And so that wasn't an issue because they had already gone through the whole identification process in that space. But then now with the in-home provision of care, there are several ways you can do it. One way is if they have been to the clinic and they are associated with the clinic, and the clinic has already provided that identity verification, but then gives you the link, you can use the clinic's identity verification process. You can also ask the patient to just show you their driver's license, or if you don't have video, then you might have to ask them to verify their date of birth or something like that you can identify. But there's also some really cool things coming on the web of down the pike of virtual identification. But without video, that's one of the reasons I think that you have to be really careful in the space of the DEA and prescribing controlled substances without video. I think it's important that we be able to do that, but we have to make sure that we have those systems in place.
Oh, excellent points. Well, thank you again to the panelists. Thank you to all of you for joining us. This is recorded. I'm going to turn over to Aria to take us away, and I hope everyone enjoys the rest of your Wednesday.
Thank you, Tara. Just a reminder that our next webinar will be held on Thursday, July 18th, and that will be on priority setting in digital health, hosted by the Pacific Basin Telehealth Resource Center. Registration information is available on the NCTRC website. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the Southwest Telehealth Resource Center for hosting today's webinar and to all of our speakers for their presentations today. Have a great day, everyone.
Take care. Thank you.